Q&A. But as Penny said, if you have any questions along the way, just type them in the chat, and I would be more than happy to take those questions as we go along. But what I'm going to talk about is something that's been near and dear to my heart for over 30 years. So I have been a trauma clinician and researcher for 30 years, and I got into this because I was very, very fascinated by trauma and its impact on adult survivors of childhood abuse. And even as a graduate student, I went to university asking the question of what's the best way to treat PTSD in childhood trauma survivors. And I was startled to find out that the studies that had been done on trauma, even in the 1990s, were on combat and were on sexual assault, but there was very little on other types of trauma, and there was very little on adult survivors of child abuse, sexual or physical abuse. And so I began doing a lit review, and I found that the 4 studies that had been done looked at attachment disorder, looked at anger, looked at esteem, and things like that, but there was nothing really looking at an evidence-based treatment for PTSD as a response to child trauma. So I was funded for the first study ever to look at PTSD from that perspective, and the treatment that I chose to use was cognitive processing therapy. From that work, I was able to make a wonderful connection with the original creator of cognitive processing therapy, and it led to us doing a lot of research over the years, where we now have a manual that encompasses all types of traumas and helps people. And so what I just want to take is a little bit of time to introduce you to this idea of what is CPT and how is it perhaps relevant or useful for you in the work that you're doing, so that you can decide if further training in CPT would be helpful. And so what I'm going to do is just go ahead and show you my slide deck and move the slides forward here and talk a little bit about what it is. So first things first, CPT is an evidence-based short-term therapy. So this is not a long-term therapy. And sorry, I think it just played around the screen. There we go. This is not a long-term therapy. It's 7 to 15 sessions, and it's very much a specific protocol of cognitive behavioral therapy. So it's based very much in both Beck and Clark. They have a lot of similarities in terms of the terminology, the way we set up, and it's very much focused on the idea that PTSD is often met with comorbid depression and anxiety and other disorders that cognitive therapy is actually very effective at treating. But this provided an evidence-based short model for treating PTSD and all of those relevant issues. And it can be done in group or individual or even a combination format. And I think of those combination formats as being really helpful in your residential, your day treatment, your IOP-based programs. That's where we find we get a lot of interest in that combined protocol. But it could also be done outpatient as well. I've definitely seen it done there. So in terms of what we're going to be talking about, these are the manuals. So this is the manual that's currently out on the left, and on April 11th, the 2nd edition comes out. So I didn't want anyone to run out of here and buy the book and then be surprised that, oh no, it's now 6 weeks old. So I really want to highlight that the new manual is coming out on April 11th. It's already, I found it on Amazon even for pre-sale. And so it is coming out, and I am training you on the new manual information. And you say, well, what are the big differences? We did a lot of work since the first one came out in 2017 to think about alterations that we could base some research on that would be more helpful. So simplifying worksheets, simplifying language, making things more accessible to a wider base of populations, making it easier to translate it into other languages, since that's something that we're doing a lot of to kind of facilitate the rollout. All right. So what the treatment rationale behind CPT is in general is the idea that people have stalled out in that natural recovery. And what we like to think about is the idea that most people will develop symptoms of PTSD if an event is significant enough. And so we know that people will have, flashbacks, even if they don't go on to develop PTSD. Some people will say, I didn't feel safe driving for several weeks after I was in my accident. I recently met a therapist who someone had broken into her flat, and she said, I couldn't stay there for 2 weeks. I couldn't stay there. I was so petrified that someone was going to break in while I was sleeping, even though they broke in during the day. I thought it would happen again. And she said, but then 2 weeks later, I went back. I had a reason to be there, and I never thought about it again. It was just not, I would occasionally, it would cross my mind, but it was never a panicky thought. She said, how did I go from so petrified to sleep there to literally being able to go back one night and it not being an issue? And so I talk a lot about kind of natural recovery that happens when we're allowed to recover, when we're supported in recovery, when we've got the genetic predisposition to recover, right? There's a lot of variables that go into who gets PTSD and who doesn't. And when those line up properly, you recover. And we know that most people actually recover. Depending on the study, 70 to 80% of people that experience traumatic events naturally recover. So I'm sitting here thinking as a clinician, if we know that most people get better, what gets in the way? If most of us have symptoms and then they go away, then what gets in the way of the rest of us from being able to do that, right? And so one of the things that we know is that avoidance of the trauma memory keeps the person stuck. And we know that that prevents often them working through any of those problematic trauma-related thoughts or triggers, and they begin avoiding more and more. And they get supported in avoiding because they feel better when they're not getting triggered. And so what happens is it becomes this kind of self-fulfilling circle of, I don't want to think about it, I don't want to feel it, and now I can't, right? And so they become more and more stuck. And then you see the overgeneralizing of their thoughts and feelings and triggers to other things. So it's not uncommon for someone, I use a gentleman I worked with recently, he was hit by a bread truck, so bakery, and it hit his car quite significantly. And he started having problems when he would go out on the road where he couldn't be around any truck that had that label on it. But then it began to be any delivery truck, any electrician truck, any truck of any size more than a small car. And he would start white knuckling his hands on the steering wheel and pulling over as fast as he could because he was so petrified that they were going to hit him, right? And so that overgeneralization comes in where they don't get to recover, right? So our cognitive focus techniques that we use in cognitive processing therapy help that individual move past these points of being stuck, and we like to call them stuck points, and move towards recovery. Now, you may know from, old school cognitive therapy, there's been a lot of terms that have been used, like automatic thoughts, intermediate beliefs, core beliefs, rules, disruptive patterns, cognitive distortions. And we find a lot of these come across as very labeling to clients and sometimes off-putting to clients who will look at me and go, what I think makes sense. I believe in what I think. And so instead, we like to think about stuck points that are keeping you stuck from recovery, and we can help you decide if those are things that you want to continue to think. So how it works, and then I'll go through this in a little bit more detail, is we start like any therapy with education about what we're going to do. And then we talk about thoughts and emotions, and we get into the whole process of the biology, how recovery works. We talk about the idea of trauma processing as being something a little bit different than maybe what they've heard, in that they don't have to talk about the trauma to get better. And if any of you were trained back when I was, the kind of rule of thumb for training was that we had to make them approach the memory. And we talked a lot about the idea of approach had to mean either talking about it in first person present tense, like exposure-based therapies, or it had to be EMDR where you thought about it in your head, or it had to be writing a written narrative of it. But on some level, they had to approach the memory and process it that way. And in fact, I was taught in training for all of these therapies I've mentioned, things like make them cry, Kate. Make them feel their feelings. If they're not doing it, push harder, right? And it's so fascinating for me that the words like fragility and readiness showed up right about the time that we were forcing people to talk about their traumas. And I always kind of look back with some chagrin that here we were saying, you have to make people talk about the trauma. You have to make them process it by writing it or thinking about it or reading it. And then we had to talk about the other side, which is people aren't ready to do that, and people are avoidant, and people are resistant, and people are, fragile, and we have to get them ready now to do that. Well, what about not making them do that? What about the idea of Can we help people get better without making them go through the trauma? Can we instead look at the meaning that the trauma has had in their life and allow them to feel safe approaching those emotions that are tied up in the trauma, because we give them part of that working brain back that helps to control that for all of us? And then look at that meaning without ever making them go through that whole trauma script that they're petrified to do. And so often, trauma can be fear-based. Sure, it can. There can be something, but it can also be shame and blame and guilt-based, especially if you do child sexual trauma. There's definitely shame and blame and interpersonal violence and in sexual assault and rape. And so what this allows us to do is make people not have to retell things that they find disgusting or shameful. And I've had a therapist say to me, well, should they have to? I mean, isn't that about recovery, being able to talk about it? And I've looked at many a trainee and I said, do you really want to ever tell me the most disgusting, horrible shame thing you've ever been through? I mean, I don't think most of us want to go to therapy and talk about that. But if they do, we have good therapies for that. We have wonderful therapies that for people who want to talk about it. This just gives another option. So we're going to use our cognitive techniques then to help achieve a more balanced view of themselves, the traumatic event or events, other people in the world, and we're going to call those stuck points and help them figure out how to become more balanced in all of that. All right. So the research at this point started, as I mentioned, with with sexual assault, especially in women. And then we followed with female child sexual abuse survivors and then moved into combat. And at this point, we have done studies all over and focusing on all types of trauma, from natural disasters to school shootings to wartime-based traumas, to you name it. We've included them into our studies, and some specifically focusing on those as areas, and some just opened as clinic-based studies. And we've done our work in about 5, actually now 6 countries. I forgot Egypt has added on a study more recently, and over 50 randomized controlled trials on CPT showing its effectiveness. So at this point, I can say happily that there isn't a type of trauma that could come into my clinic that I can't say was included in a study. So we really have focused on all, and vast majority of our patients have come in with multiple traumas. That's very common for us, is to have people who've been through lots and lots and lots of traumas. A few with single incidents, but not the majority. Right. And our studies have been done on ages 12 on up. So, if any of you have been trained in Esther Deblinger, Judy Cohen's work on TFCBT for kiddos, that's a wonderful therapy. Actually, I was funded at the exact same time for my first study that Esther was funded for TFCBT. And I always say TFCBT kind of takes care of the little ones, and then CPT and the other therapies in adulthood kind of pick up at age 12 and can move us on forward. Right. And as I mentioned, feel free to jump in with questions at any time on any of the stuff that I'm covering here. So we do have a website that I will bring you back to that has tons and tons of resources. But one of the great things that we have is that even though this is a published text and owned by the publisher, is we are able to create just the worksheets and put them into translation format and give them to folks. Now, sometimes people will actually choose to translate the entire manual, and that is a publication negotiation. And so we've had the Japanese consulate group come in and work with us, and their version is available on Amazon. The Polish text is available from University of Warsaw Press. I understand the Korean has come out. I don't know the publisher. I just got the manual, and I can't get a Google Translate to work for me to tell me who the publisher is. So we do have the Korean book as well. But all of the other translations we are uploading onto our website. So I'll give you tips on how to get to the English versions later. But if you do choose to do CPT, the beauty is that you can work with clients from all over the world in using our worksheets in a language that might be more accessible to them, instead of just always using them in English. And let me make sure I didn't go too far. There we go. Okay. So the first thing I want to highlight is the pre to post treatment effect sizes for our clients who are dealing with civilian-based trauma. So none of these would be veterans. These would all be individuals dealing with, rape, assault, car accidents, natural disasters, things like that. And so I want to point out a couple of the studies here because these are things that kind of stand out for me and that people ask a lot about. So starting on the left, the CHARD 2005 study, that was actually the first published study of child sexual abuse with PTSD. And as you can see, quite a large effect size. And for those of you saying, oh goodness, I don't remember my stats, Kate, anything that was a 0.8 or higher is considered a large effect size. A 0.6 is medium and a 0.2 is small. And in the United States, our FDA, our drug commission, will release things like antidepressants, cancer treatments, COVID vaccines, all somewhere above a 0.2. And so you don't have to be that high in order to have something get released to market. So when we're talking about having studies with child sexual abuse with 1.57, those are really, really strong effect sizes and show that we can have a really large impact on those individuals' lives. A couple other ones that I highlight, the Jen Bass study, which is the next one, and I'll highlight that one in a minute on another slide, is that study of working in a combat zone where people are being attacked and still being able to treat PTSD. And I will tell you, probably one of my perhaps most guilt-induced moments of my career was when I realized that training my students that following statement was wrong. So we used to say you cannot treat PTSD while people are experiencing trauma. And it would not be uncommon for people to be referred to my clinic who were living in interpersonal violence situations, teenagers or kids where we couldn't get them out of the home because the child protection services wouldn't remove them. And we'd have these people in traumatic situations and we wouldn't be allowed to treat PTSD because the rule was you don't treat PTSD while receiving trauma. So we would do safety planning and then just coping work and hope that that was enough. And I feel really bad because then the war in Iraq and Afghanistan hit, and all of a sudden the US military came calling saying, you need to train us now. We need training in PTSD treatments like CPT and exposure-based treatments for these troops that are literally in the country right now. And I sat there saying to myself and talking to my colleagues, and we were all realizing we're literally saying you cannot treat PTSD while receiving trauma, yet we're over here training therapists to do it in the middle of a war zone. And then I came home and I was frankly, again, startled by the fact that we hadn't been treating first responders, police, paramedics, any of our firefighters. And it was not uncommon for a firefighter to come to therapy with me and say, I'm going to go on shift in a few hours and I have no idea what will happen. And again, realizing that you can treat PTSD while being traumatized, and it's not uncommon for me to treat a police officer from the front of their car or on a Zoom call, or to treat a firefighter who goes out of my session and 3 hours later has a pediatric death. Those are very normal things, but really blasting that idea that you cannot treat trauma, while trauma is happening. So I'll be talking about that Bass study there with the second big green arrow. And then the third green arrow is Rosner's study out of Germany on adolescents, and showing that even adolescents, and a lot of people say, well, you can't do cognitive therapy with adolescents because they don't think the same way and they don't have a fully developed prefrontal cortex. And I think Rosner's work was absolutely fantastic at showing, well, yeah, we can treat it. And the nice thing about the CPT is it actually supports the prefrontal cortex and helps build it even more. So it does help out a bit for those clients working through it. Right? And then for those of you who are working with our combats, veteran or active duty military, as you can see, the results are less strong across the board. We have noticed that typically in most countries that people in active duty or veteran status do not perform as well. Now, one of the things that we did notice in the veteran population is that they often are worried that their scores, if they're used in the chart, can impact them and take away any sense of service money that they're receiving, compensation. And so we became very aware that many of these studies were impacted by people who were very, very concerned about receiving funding in an ongoing basis. But then we found the other side of the coin for those who were actually in active duty, that they were worried that they would lose their career, that they would lose their security clearance, that they would not be deployable, that they would not be able to keep their weapon. And so it really caused us to think a lot about, when we do a study, how can we make sure that they're not concerned that the data is going to get into a file that's going to hurt them one way or another. And the better that we've done at that, you can see the scores start doing better. So even the Simpson article that's in press actually has some of the best data. So as we've moved along the pipeline, the studies that have done better at controlling the data actually have done better. And right in the middle, that JACK study in 2018, that was done on TBI patients who had PTSD, so traumatic brain injury. Again, showing how effectively we can do CPT even when people have suffered from a traumatic brain injury. All right. So all this to say, lots and lots of studies looking at different things. But as I promised you, I wanted to go back and look at our study that was done by Jen Bass and Deborah Kaysen in the Democratic Republic of Congo. As many of you know, the Congo is very much a war-torn country, still experiencing a lot of difficulties. And we were asked to help out in terms of working with them because of the fact that therapist eligibility or availability, is quite slim. It's very difficult for villagers to get to a therapist. There are not a lot of therapists at all. They're all in the major cities. There's not the ability to do telemedicine out to villages to do therapy. And so the ability for these people to access care is slim, and they're currently going through a war. And so what's happening is there are a lot of militia groups that attack villages in the night. The women and children will run into the forest or the jungle and then hope that the men and adult or adolescent males can protect the livestock and the home areas. And so it's a very, very scary part of the world to be in for a lot of these people with very limited care. So what we were able to do was create therapists in the village who had high school education or less. So when people say, oh, cognitive therapy is too hard, I can't understand all those principles, you have to have a lot of schooling. Well, our therapists had a high school education or less. And what we were able to do is give them satellite phones so that we could have a central therapist in the Congo call out to the villages to give them supervision. We were able to have half of the participants go through supportive treatment as usual type therapy and the other half through cognitive processing therapy. And most of the participants were illiterate. So what we did is simplified the worksheets. So we took the worksheets that we've been using, simplified them for traumatic brain injury, and then simplified those even more to work with our participants in the Congo. And the participants would memorize the concepts and the forms, and it made it much, much easier for them to just remember them, but still do them. And the war was going on. And in fact, one of our women was killed during the study. And they were assessed at pre, post, and 6 month for the main study in the beginning. And here's the results. So on the top graph, you see the Hopkins measure of anxiety and depression, and the top group with the dark green line is the supportive psychotherapy group. The bottom line is the CPT group. The second graph is the PTSD measure. The top line again is the supportive therapy, and the bottom line is the CPT group. And in both cases, you could see that CPT had a stronger improvement on anxiety, depression, and PTSD. And I always like to highlight two important things of this study. One, the fact that we know doing something helps. I never want anyone to think that I'm a drink the Kool-Aid clinician, that as CPT is the only way to be. I'm trained in pretty much every evidence-based therapy out there, and some that turned out not to be evidence-based, because I know that not one thing will work for everybody. And so the idea here is that doing something helps. And I think of the evidence-based therapies often as, will it work faster? Will it improve somebody's condition more? And will it last longer? And that's where I think the evidence-based therapies have shown, outside of other more regular treatments that clinicians have often used in the past, because looking at my yellow bar at the bottom, they published a 10-year follow-up on this and found that the results, especially related to CPT, largely held. That even in a very remote area without follow-up care, that people do get better when they go through CPT, and it does create the changes in the brain to help them maintain a significant improvement. All right. So just a little bit more before I go into details on how it works, a little bit more step-by-step stuff. I do want to highlight that we did publish during the pandemic an article on cognitive processing therapy and looking at it from a perspective of telehealth. We had been doing telehealth for years and years prior to the COVID hit in the United States. And in fact, we had been using it in the Veterans Administration for our active duty and our veterans. And we'd been using it in remote areas of the United States where we could only get to them on a Zoom or Teams call. And so this had been around for quite some time. So when COVID hit, many of our clinics morphed very, very quickly. And people kept asking, how do you do that? And so we published an article 3 months in that shows how you can develop and use cognitive processing therapy in your own practice via telehealth. Now, obviously, COVID is hopefully significantly minimized in our parts of the world, but the telehealth issue is still there. How do we do an evidence-based, interactive, homework-driven therapy using telehealth? And so this article is out there for you all to give you lots and lots of tips on how to use CPT in that environment. Okay. So any questions so far before I jump into the next one? Feel free to throw them in the chat if anyone has one. I'm trying to monitor it, make sure I'm not missing anything. All right. Okay. So next, I just want to highlight impact on outcome, because these are the things that most people ask me about in terms of their own clients of, does CPT work with my people that I treat? So first, women do a little bit better than men, but both do quite well. We have done studies in countries from Japan to Italy to Azerbaijan to, oh good, there's one in the Q&A. Hang on, I'll go pick it up. To let me think, our most recent ones, Kurdistan, Iraq, the Congo, as I mentioned, First Nation, Native Americans. So we've done lots and lots and lots of studies throughout. And what we've shown across the board is that these studies show that CPT crosses well across cultures. So I think you'll find that it can be very easy and effective for you to use, even with clients that don't come from traditional European cultures. So I am seeing, for some reason, not the Q&A, but only the chat. So if folks wouldn't mind putting things into the chat and not the Q&A, for some reason, I don't think I have access to the Q&A.
Doesn't seem to be working. Sorry, Catherine. Just had a look. So if
yes.
Put the Q.
Penny, do you mind reading the Q&A to me? And folks who are out there, if you don't mind putting your comments into the chat box.
So the question is there a question in the Q&A? We can't access the Q&A. I'm going to do some work in the background, see if I can get it working.
Okay, yeah, it looks like folks are trying to jump in. Oh, here we go. Thank you. So the chat is working. You all are wonderful. Thank you. Okay. So a question on what will I cover? A sense of who does CPT best and worst. Oh, excellently. And Vanderkolk talk you went to recently suggested that talking therapies like CPT or CBT can be less effective for people who experience long-term abuse in childhood. The body-based approaches using psychedelics supported therapies can be more indicated. I find that very interesting that Bessel's saying that, because we haven't really done the research on that. I know Bessel's very, very interested in the body-based work. And of course, he's been doing some things like yoga and other things like that, but he doesn't even have a study done yet. I don't even know if he started, but I do know he got money for that. So, and in terms of the psychedelics, we're very interested in the psychedelics. And I actually am going to put in a study to do a CPT psychedelics. My dear colleague and friend Candace Munson is already in that space. So whether you're working with psilocybin or MDMA derivatives, I mean, I think those are very, very exciting. And I can get in as we go through CPT if you'd like. I can go in a little bit about why those are effective or could be really exciting for us. But in terms of this thought about working with people who have what Bessel, in this case, it looks like was mentioning long-term child abuse. Well, that's my area. So I'm a little disheartened that he would have said that were less effective there, because actually one of our strongest effect sizes we've ever had on a study was my study of long-term child abuse. So I think that there are a lot of reasons why some people are more severe than others. And I think the trauma characteristics can be one of those variables, but we now know from the research that there's a lot of different reasons why people are worse than others. And so I think it would probably be pretty important to be aware of the differences that go into each individual patient that comes in. And I wouldn't make a sweeping comment about a type of trauma doing worse than a therapy. Without actually having done the studies. Like, we have enough studies on combat to show that they do less, but I wouldn't want to make any kind of sweeping generalizations without having done that research. And then another person asked about neurodiversity. That is a very exciting area, Hannah, that a lot of us are getting into. And I will drop that in just a second, because I do want to talk about that, because I think it's very important. So let me highlight a couple of things. So one of the things that I want to highlight next is the issues of culture not being relevant. But the next one, if you look down below, and it says era, I'm sorry for that. That should have been corrected to LGBTQIA+. And we know that individuals in some of our more recent research that I've been putting together who identified themselves as non-white and non-heterosexual started worse at the beginning, but ended better. They ended better than their counterparts. So that tells us that, yes, they start off worse. And I threw into that group as well some new patients that had come through that identified as being transgendered, that is identified as being gender fluid. So really allowing for the gamut of people to express themselves as they chose. And what we found across the board was often their traumas were tied to their identity. And especially if they were LGBTQIA+, and non-white, definitely their traumas were often tied to their different pieces of identity. So them being worse than a more traditional white heterosexual client that was included in original studies, they were worse. But the gains that they made were even better. And that really shows that when identity and trauma are tied together, some of that cognitive work can be incredibly helpful. But that led me into this new area of ASD and even neurodiversity, and thinking about some of the patients that are coming in, and so we've been really broadening out to all sorts of things. So whether it be ASD, whether it be the whole spectrum, whether it be schizophrenia, thought disorder, we have a paper coming out on that recent in the next, I think, 3 weeks. So a recent submission. And what we're finding is that in all of these cases, CPT is working really, really well, My big one is, as a child abuse person, I cannot talk about PTSD without talking about personality. Borderline personality disorder traits and the disorder itself do not predict CPT outcome at all. We also found that for people with a substance use history, I think so often they are passed over to substance use programs, told to create sobriety before they're willing to come in. But I find it so interesting that we don't do that with people who are eating or running 6 marathons a week, or all these other things. We go ahead and talk about their trauma. And in eating disorder companies all over the world, we're training in trauma therapy as part of the eating disorder therapy for many of those patients. Well, we now know from several people's work that when we treat the substance use before the PTSD, often they have horrible relapses that often result in worse outcomes. But when we actually treat PTSD, the substance use goes down. So we've had great response there. We know that people who go through CPT have less reported interpersonal violence afterwards. And for those interested in this idea of complex PTSD and the idea that, there are a lot of variables that can go into complexity, including trauma type and trauma history and other variables. We know that there's no difference in clients who identify as complex or non-complex when it comes to CPT. And part of that obviously is personality disorder status, and there's no difference there. And so I just put a couple slides together to show you all that we have looked at a lot of these different things and the importance of this. And so first of all, we looked at CPT in general over time. And this was a study of CPT versus prolonged exposure that went up to 10 years later. And again, just like the Congo study, we show that once people get better, they stay better. They stay better. So it really does show that idea of, maybe PTSD is something we can change in the brain, and it is curable. So looking at kind complexity again, because I think that's an important issue for a lot of folks is, how can this treatment work for these patients that come in just in worse shape in a lot of cases than our other, traditional patients that maybe come in with a single trauma and a single disorder, and I can assign to my intern or my student. But how about those clients that come in with more disorders, that more disruption? So using Briere's trauma symptom inventory, we decided to compare child sexual abuse survivors versus non-child sexual abuse. Since a lot of people, when we talk about complexity, we talk about years and years of childhood trauma. But we also had already shown that personality disorder status didn't make a difference. It made no difference in how CPT looked. So I thought Briere's measure was great here because it picked up anxiety and depression, but also anger, intrusive experiences, how much avoidance they're doing, but also dissociation, sexuality concerns, dysfunctional sexual behavior, impaired self-reference, and tension-reducing behaviors. And all of those, especially on the right side of that graph, are associated with complex PTSD symptomatology. And what we found is in between the child sexual abuse and non-abuse group, impaired self-reference was the only one that was significant out of the gate. And then sexuality concerns and dissociation were trending towards significant. So there were those differences. So again, if this treatment doesn't work for our clients who are saying that they've got more complexity in their presentation, then we should see problems. But look at what happened at post-treatment. The same. They did the same. And at 10-year follow-up, 5 to 10 years later, where are they? Still better. Still better. So even if clients come in, and getting back to that earlier question about these people with long-standing childhood trauma histories, what we show is they do fine, even compared to those without a childhood sexual abuse history. Just fine. Okay. All right, so I'm going to pause there, ask if there's any other questions about population groups or data or anything like that before I spend the next little while talking about the therapy and how we go through it. So anyone want to write anything in the chat before I jump in? I don't want to leave you behind. Feel free to jump on in. And if not, I'll give it a second and wait for the interweb to pick it up. So don't worry if yours doesn't come quickly. Sometimes they do take a couple seconds, and I promise I will come back to them if they don't. All right, so please don't let that worry you. All right. Okay, and it looks like we can now see the Q&A. Okay, good. So it looks like it's all fixed. All right, so thank you. All right, so folks, just to make it easier for me, because I am not seeing the Q&A even as a button in mine, if you don't mind just jumping in and using the chat for me, that would be lovely instead of the Q&A. I know you guys have access to both, but for some reason the Q&A is not showing up for me. All right, okay. So with that said, let's talk about then an overview of how you would do CPT if this seems to be something that would interest you. All right, so first things first is pre-treatment assessment. You're going to do everything you would naturally do with a trauma survivor. So you're going to jump in and you're going to start with doing some type of assessment to determine, do they have PTSD? Do they have anxiety or depression or substance use? What are the issues here? So I don't want to change anything that you would naturally already do. Right? And we use the same assessments that you probably are already using, things like the PHQ or the PCL for your assessments of anxiety and depression. And then what we want to do, though, is educate our clients about CPT. And so I think it's really important to think about, educating them about this, making sure it's an informed choice, right? And then going ahead and helping them process through the trauma without necessarily having to talk about it. And then learning to challenge or explore those beliefs and assumptions and stuck points, thinking about the main themes that have been impacted by trauma, and then facing the future, right? So to start them off with, pre-treatment. So again, as much as needed, we don't tend to recommend a lot of readiness. We find that when patients get put into a lot of readiness work, they tend to actually drop out more. They tend to be less willing to do evidence-based therapies. And actually, there's some data suggesting that suicide rates are a little bit higher in clients that are asked to do the readiness work before dropping into active PTSD work. Now, I want to put a pause there and say that if my client had active suicidal intent, that would be a different story, or was so dissociative they couldn't even sit through a treatment session, that would be a different story. But for most of my clients, whether they're suicidal, whether they're drinking, whether they're using drugs, whether they're eating disordered, as long as they're willing to sit through a 50-minute session with me, I'm going to go ahead and start them in CPT if that's the therapy they want to do. Right. So first off, let's assess, right? Do they have PTSD or acute stress disorder from our wonderful work of McNally and Reg Nixon down in Australia? So first off, do they have, right? But next, what we want to do is describe this and talk with them about how it may be a little bit different. And if for clients that have never seen homework before or practice assignments, that can be new. But again, we're going to sell it. We're going to sell practice. And so I want you to use, if you're doing this, metaphors that would work for your client population. So whether it be video games and talking with how many hours does it take to learn how to do Zelda right, or how to do Fortnite right, or whether it's someone who is obsessed with sports and talking about how many hours do some of these professional football players put in to do it right, even though they play all the time, yet still they practice. But why do you practice? If you're that good, why do you need to practice? Or it could be a singer, right? I've been really big into Taylor Swift lately or using this example because of her international tour. So everyone seems to know who Taylor Swift is at this point. And so I talk jokingly about the fact that even when her boyfriend was making this big run in football, she didn't go to all his games. She was going back out on tour to Asia and to Australia, and she needed to go and do what? Practice. And I joke with my patients saying, why is Taylor Swift practicing when she was just on tour for 9 months? Shouldn't she know it by now? And my clients all go, well, no, you have to practice to really get it down. And one of my clients informed me that she runs on a treadmill for 3.5 hours while singing her songs. Oh, well, why does she do that? Right? And again, it's really helping them understand the criticalness of practice and helping to change the brain and helping to make improvements. And so I do a little bit of motivational enhancement about, why would you want to do the homework, and, what's keeping you stuck, and what avoidance strategies are you using, and how have those been helpful, but how have those not been helpful? How have they gotten in your way? And we have a therapist contract that's optional. Some therapists like it because it kind of explains ahead of time the expectations for the therapy. So it can be really, really helpful at them thinking about, what do I need to do and what am I going to have to do as a patient in this, right? So who does it help? As I mentioned before, what we want to do is start with this idea of working with people who have PTSD or acute stress disorder or subthreshold PTSD. Other not otherwise specified type PTSD type disorders are fine, complex PTSD. And then what we want to think about is, the idea of not ruling out just because someone has depression or anxiety or active substance use, as long as it doesn't need detox, right, for inpatient, and personality disorders. All of those are people we would include. And I want to highlight something really, really important. My dear friend and colleague, Patty Rezick, has shown, and then we have followed up and shown here as well, that individuals with suicidal ideation and even intent with a plan do well in CPT, and suicidal thoughts and behaviors go down immediately, starting with session 1, and then continue to go down. So it's actually a really, really powerful treatment if we're talking about prevention of suicide, because so much of suicide we now know is linked to the sense of burdensomeness and belongingness. And those are exact things that we challenge and help to fix in CPT. And so, it really does work in those populations. So we would not recommend if the person had active suicidal behavior with intent that was imminent. That's where we would probably do something else. But if it's not imminent, definitely we would start them in CPT. Okay. The active unmedicated manic patients, bipolar mania, that may be potentially harmful to themselves, those I would also want to wait on for medication. And then current psychosis that's unmedicated, where they have a very difficult time talking about reality, I would want to wait on as well. But as I mentioned, we have done CPT with psychotic patients quite successfully. Okay. So we would want to think about all of these things and not maybe rule out as much as perhaps other people have told you to, because we find that actually keeping these very, very difficult patients in CPT can be very, very effective. All right. So we then are going to think about this idea of how they've gotten stuck. So the beginning of CPT is going to be introducing this idea of stuck points and having them write about how the trauma has impacted them. Not what happened, but why they think it happened, why they believe it happened, right? Why they believe this was an issue for them, why they believe it's still an issue, you know, how they've been second guessing or blaming or questioning themselves for what has happened. And then we're going to help them look at the meaning they've made in terms of their stuck points. So their thoughts of, if only I'd done something different, or I should have known this was going to happen, or it's my fault, or it's my mother's fault for not protecting me, or my friends should have known that he was a rapist. You know, all of these, you know, shame, blame, guilt, even fear cognitions about why this event happened, about the past and the trauma itself. But then we're going to look at all the ways it's overgeneralized, the big distortions, right? But thinking of those instead of distortions as stuck points. So all men are rapists, all Middle Easterners are jihadists, all bread trucks are bad, right? If I get close to other people, they'll hurt me. If I get close to other people, they'll die, right? I'm not capable of intimacy. I'm not capable of love. I don't deserve happiness. All those broad sweeping things that our clients beat themselves up with. And what we're going to do is in the beginning is educate them about this idea of being stuck. Talk about the biology of the brain, how it works, what the problems are here that's preventing them from recovering, and then have them go through this impact statement to figure out where they're stuck without ever asking them any significant detail about what explicitly happened. Right. So I see that some of the questions are still going in the Q&A. Does somebody want, Katie, do you mind? Can you read out any that are there now? And I'd be happy to answer them.
Yeah, no problem. Sorry, we're just trying to sort out the Q&A in the background.
That's right. Or if we want, you could copy and paste if that's easier for you, my friend.
I've got no new questions that have come through. Can you see some new questions?
Oh, somebody said there's still some Q&A. Oh, issues for admin. Okay. Okay. So yeah, so it looks like there's some Q&A going for admin. So I guess that's not me. So I'll stay out of that. Okay. Thank you. But if any come through to you all that look like they're to me, feel free to shout them out to me.
Will do. Thank you.
Thank you. So again, the idea being that what we're going to do here is focus more on the present tense and even how they're mind reading about the future instead of bogging them back down into the past tense and into the, you know, distress they might have about the past tense. Okay. All right. So with that, then what we're going to do is focus in on using some of the basic cognitive tools that you may have learned from Beck or Clark or, you know, any of the other groups, Eller's groups. But what we've done is change them up a little bit and in many ways simplified them in ways that we have found to be helpful for trauma survivors. And in this case, we took Beck's original ABC sheet, but we took off his D on the end. He had that do column on the end because we found that clients would get very lost in that column and they'd go into these, you know, almost diatribes about all the horrible things that they would do or have to do or behave as they were moving forward. And instead, what we wanted them to focus more on, talk about what happened, what did you tell yourself, and then how does it make you feel? But look at the bottom of the page. This is the power. We then help them by asking 3 critical questions. Is what you're telling yourself in column B realistic? And a lot of times my clients will say, yeah, it is. And I'll say, but is it helpful? And they'll say, no, it's not. Or sometimes they'll say, it's not realistic and it's not helpful. And on really rare occasions, they'll say, yep, it's realistic and it's helpful. But what I'll focus on is in that 3rd question at the bottom of the page, which is what? What could you tell yourself on future occasions that would actually lead to you feeling something different? And a lot of times they'll say, I can tell you what I'm going to say, but I don't believe it. Or they'll say, I don't know any other way to look at it. And sometimes, well, that's when we use our wonderful therapy techniques of what would you want your friends to think? What do you want your daughters or your sons to think? What if people told you? Because what we're doing is just trying to create flexibility, not by telling them that what they're thinking is wrong, but to remind them that we always have options about how we want to look at situations. And it's really interesting. The whole goal of this sheet is just to create a connection between thoughts and feelings and to introduce that idea of flexibility. But I'm always pleasantly surprised by the number of clients who walk out of this worksheet going, wow, I never thought that there were options about this. I just thought it happened, and that's the way you think about it, and then you go forward. And it's just a little bit startling to realize that I can think about this differently. And when I think about it differently, I feel different. And so we can start with just really simple examples from their life, things like that, but we don't have to. So someone asks, is this done before the normal TFCBT reliving work? So great question. And if we're doing TFCBT, obviously you would do TFCBT here, right? But if we're doing CPT, right, we would not be doing the reliving work. Okay, so there's none of the reliving work in this, right? It's a little bit of a different focus. And I know a lot of folks from TFCBT have been asking if they could get rid of the reliving work. Right? Because one of the big things that we did in CPT is take out that trauma narrative where they don't have to do it, but it's still an option. So this would be before that if they choose to do the narrative here, right? And I have ever heard about flip the narrative. I have. And you know, it's a similar idea, right? It's a similar idea of change the script, flip the narrative. Right? Thinking about it. And this is a great sheet to do that. Even if you're not doing CPT, this is a great sheet to do it because again, it focuses less on that do column, right, Emmy, and focuses more on, you know, what am I telling myself, right? Yeah. And I think so often I've had clients write, you know, 6-point font in my little box here, and they'll write and they'll write and they'll write and they'll write all in the do column. And I'm like, if we just cut that off, what can we focus on? What are you telling yourself? How's that making you feel? And what else are the other choices? And clients are often really surprised by how much messaging they give to themselves that just isn't helpful. And we can see it as therapists, but I can't point it out because then they'll yes, but me, yes, but me, yes, but me. But by actually doing this on the worksheet, they get to point it out. And so we're going to just introduce this simple tool. And the other great thing is that what they write in column B is often stuck points. And so we can help them build a list or a log of stuck points that we can use to help them challenge what they're thinking and expecting later on in the therapy, right? So this is just the beginning. We're going to just start here. And then what we're going to do is go on to this idea of processing the trauma, but not in the traditional way of having to relive what happened, write about what happened, talk about what happened, think about what happened. That's going to be an option, but it's not going to be a mandate. It's not going to be a mandate. So what are we going to do? So the first thing we're going to do is help them really challenge or explore where they've gotten stuck, especially in the self-blame areas, the blaming of the non-offending person, like the non-offending parent who had nothing to do with it, but they're blaming them for not knowing, or any of the work where they think if only I had done X, it would have been wine and roses, right? And so we're going to use a worksheet called the Exploring Questions worksheet to really explore. And some of you are going to find those very familiar. They're from originally the Beck and Clark world of challenging questions and thinking of distortions. But we're going to think of these more as exploring instead of challenging. We're going to soften that language, make it feel more approachable, and allow them to use the exploring questions to really think about the leaps that I've gone to in terms of my stuck points. And then we're going to assign the thinking patterns. And yes, those have been taken from those disruptive or problematic or dysfunctional thought patterns that you've read about or heard about. And in this case, again, taking that pejorative language off, they're not disruptive, they're not dysfunctional, they're just thinking patterns, and allowing them to think about, what am I doing? Am I overgeneralizing? Am I jumping to conclusions, right? Am I mind reading? What am I doing? And allowing them to really think about what they're doing when they're, interacting with people or themselves throughout the day. And so part of what we're going to use in CPT is this idea of Socratic dialogue. And it's an absolute cornerstone of our cognitive therapy. You know, we're going to use this continually from the beginning all the way through. And the worksheets are kind of the, if you don't mind, the delivery mechanism by which I do my Socratic dialogue, because they give me the guidance to have the client continue to work on these things at home and, you know, focus. But it also gives me the tool with which to help them do the sheets during the day. And so it's really this idea of helping the client look at the accuracy of their conclusions, right? Letting them really think about, is there another way to look at this? How do I really think about this? And so we're not coming across like a barrister or an attorney. We're coming across more like a curious friend, like a co-scientist, using a lot of warmth. And I did a session actually yesterday with a woman who had a lot of interpersonal violence and child abuse. And, you know, at this point in therapy, she knows me well enough that I sat there and I said, I think we're missing a stuck point. I think there's something else there. And so we began with a piece of paper on a sheet in front of us, and we're working it through. And I said, what else are we saying here that's bothering you? You know, I'm hearing something about, you know, guilt and anger. So what's the thought behind that? And so she throws one out and I said, is that it? She's like, no, I mean, it's getting closer, but it doesn't quite feel like it. I'm like, okay, well, let's keep trying. What else are you saying about why you should be guilty and how this is your fault? And, you know, and she looks at me, she goes, well, I just think I should have known. And I said, is that it? She goes, yeah, I should have known this was going to happen from the day I met him. Stuck point we didn't even have on the log, and we added it midway through therapy. So just using those Socratic skills to help them figure out both where they're stuck, but also clarify how they've jumped to the conclusions they have. Help them, you know, think about the assumptions they've made about what this means for life. All bread trucks are bad. All men are rapists. You know, look for the real evidence and explore the deeper meaning. And so this is going to be a hallmark of what we do. But like I said, you're going to be using our worksheets to help get through all of this process as you go through. Okay. All right. And then learning to challenge by using those thinking patterns, and then finally using the big worksheet that puts everything all together, which is the automatic thoughts. So, and I put automatic, it's alternate thoughts, excuse me, the new name. This is one of our new named worksheets, the alternate thought worksheets. So we'll use the alternate thought worksheets for the entire rest of therapy, the ATW, and we're going to help them use this sheet just to kind of think through, what are my options? How can I think about it? But we're also going to add in specific, you know, 2-pagers to digest and think about on key areas we know have been implicated in trauma, such as safety. You know, how many of our clients have stuck points like, I can never be safe again. I can never be safe in my own home. I can never be safe being vulnerable. I can never be safe on a date. I can't even keep myself safe. I'm never safe alone. I can't trust myself. And that's the next theme. So going ahead and using these sheets on safety and trust, and then power and control, esteem and intimacy, and helping them think through, what are all of my stuck points in each and every one of these areas, all right? And it will really help them move from more extreme thoughts to more balanced thoughts. And what we're going to do is help them use practice assignments like these daily worksheets, one on each of these themes, but then also anything else. And we'll add in a couple of behavioral assignments to do things like doing nice things for yourself and, you know, focusing on not having to earn it to have something good in your life. And then to bring the therapy finally home at the end, we're going to review the final worksheets, and then we're going to have them rewrite that impact statement. We're going to compare the impact statements to decide, you know, where have we come in therapy? What are the goals? Is there anything else that needs to be addressed? But also really thinking about, where have I changed my thinking? What's different for me? You know, how am I going to change in the future in my relationships, in the way I negotiate situations? And if there's something else I need to refer to, obviously I can afterwards. But a lot of our clients walk away without the same issues with depression and anxiety and personality and substance and eating. But if they do, then I can absolutely refer them on for specialized care in those areas. Okay. All right. Now, if a client wants to, as I mentioned at the beginning, if they really, really want to, they can write about what happened. In a written account, we only do it twice, and we just add it into the therapy. So if they really, really want to talk about what happened, and some do, I would say probably in our clinics, anywhere from 10 to 15% of clients want to actually talk about what happened. This gives them the option to do that. They can actually write about what happened and, come in and read it back to us and have us explore then and look for stuck points about what happened. So giving them that option is really, really important for people moving forward. Okay. So it does give that option. And the nice thing, someone just private messaged me, is we have an app that can be used in every country. It's only in English. I apologize. I wish we could get it into other languages. I believe the Azerbaijani government is the one working on translating it first into Azer. But the app is lovely because it can be used for both the Android and the iPhone platforms. It's HIPAA compliant. All information is locked into the phone, and so it can only be sent out by the patient to their therapist through whatever platform they want. But for clients that have got difficulties with writing, they can dictate. So they can dictate the information into the app, and they can dictate all of the worksheets, by the way, but they could also type to text. If they want to type to text their written narrative or their impact statements, they can do all of that in the app as well. And we cover that in the training. So that's something you can learn about as well in the training. All right. So next thing I want to highlight is that not everyone needs the same amount of therapy. So when many of us helped create treatment manuals, we created treatment manuals with a certain number of sessions. And the expectations were that the client would come in and we would do these sessions, and we would then have them go away and be better. But there was a significant problem with that assumption. Not everyone needed the full protocol. And not everyone needed only that number of sessions. And so over the past 10 years, my colleagues and I have done a lot of work looking at how much do people actually need? And a couple of really important things came up. Almost 60% of our patients don't even need 12 sessions. It's typically around 8. And so what we can do is combine the session material and have them do multiple sessions in one session. So it's still a 60-minute session, but they get extra homework. And it doesn't mean extra as in extra work. It means they're going to focus on safety and trust, the modules. And so we teach that. Again, if you go through the workshop, you learn about how do you combine the protocol? How do you allow the client to get better faster? The other thing we noticed is that about 25% needed more than 12. Well, how do you make it longer? How do you allow a client to go up to 15 sessions? And when would you make those decisions? And that's a key part of this. But it allows us to flex this protocol in a way that's, excuse me, spring allergies are coming, that's more effective for the individual client. I can tell you the other thing that's happened recently is, I don't know if the word intensive or massed is being used more in your part of the world, but the idea of massing therapy together or providing it in an intensive format is something that's very, very exciting over here, where clients are really taking to the idea of, can I do daily therapy? Can I be seen Monday through Friday? Can I be seen more often? And what we're finding is that when people go through massed treatment options where they're seen more often and they're seen with the same amount of homework, but it's daily or even 3 times a week, clients are getting better faster, and they're actually having lower dropout rates. And in some of the studies, the data is showing that their improvement's even greater. So moving away from that idea of therapy is once a week, or that people need a longer period of time to process information, and really focusing on more about learning theory and what we're learning about changes in the brain and how people get better. And that when we mass things together, people actually get better faster. Okay. So to become trained to use CPT, the goal would be to attend a 2-day workshop. We have them on our website. We're also willing to host one with you all. If any of you want us to come over, we'd be happy to do one on Zoom or in person over with you all. And then we recommend folks attend consultation. That is not a mandate, but like any of the other evidence-based therapies like TFCBT or EMDR, obviously they all have consultation. We also offer advanced and group one-day workshops for people really, really interested in those things. And thanks, George. I'm glad you're interested. So George is already putting in a plug. He wants us to host a workshop. So there you go. Thanks, George. So we also, for those of you really interested in the advanced techniques like dealing with extra levels of dissociation, or dealing with that client who is suicidal, or dealing with that client who is a bit resistant to doing any work at all, you know, we do have some of those things that we cover in the advanced workshops. My dear friend and colleague, Candace Munson, who's one of the co-authors, does a great multi-day workshop on Socratic dialogue as well. All of those are on Zoom, which are great. And then for you to stay on our provider roster, we also have the CPT web course that we recommend people do afterwards. But let me show you a couple of things, because I brought you some things that are of interest to you all, and a little bit of video action to kind of help put this into play and have you think about this. All right. So the entry criteria for training, we do allow students to come to training, but we ask that if you're going to go through consultation, we want you to have a clinical supervisor, and that we then provide the consultation. So more than happy to have you get trained even as a student. So what we say is anyone who will be licensed or license eligible to provide psychotherapy in your country can get trained. And in terms of doing the training cases and consultation, we cannot be a supervisor of license, but we can be a consultant. So as long as you've got a supervisor at your site overseeing the cases, we are totally fine with that. Because what we know is that in a lot of different countries, a lot of different types of providers are allowed to do therapy. Even in some countries, mental health technicians are allowed to do therapy. And so we don't govern that. That's governed by your country. We just provide the training. Yeah. We just provide the training. So absolutely. So a couple of things I want to mention. So first things first, I want to highlight This American Life. This is a podcast that is several years old now, but for those of you who like listening to podcasts, this is a podcast that was done when a reporter for National Public Radio, This American Life, did an interview with one of our CPT therapists and trainers about CPT and sexual assault. During that podcast, the conversation turned to intensive-based deliveries, the idea that you can treat PTSD in 2 weeks. You can treat it in 1 week. That, you know, depending on the client's interest, you can really lump together a lot of sessions with CPT quite effectively. Well, the reporter, it turns out, was a sexual assault survivor and had been in therapy for years. And she pitched to the producers of the show that she get to go out from New York City to Seattle, Washington. So literally crossing the United States, because this was pre-COVID, so pre-Zoom, and, you know, making sure she was legally allowed to do this. And she went out to Seattle and she audio taped all of her therapy with the therapist's permission. So this is her reflecting on going through CPT on a 2-week focused enterprise where she did 5 sessions, took the weekend off, 5 sessions, and then recorded it, plays some of it back, but also her own kind of reflections. And one of the key things she talks about was how interesting she thought it was that she'd been in years of insight-oriented therapy and hadn't really made much headway. And literally she went away for 2 weeks and she was better. And she was just shocked at that. And being a reporter, she's done follow-ups on this and has talked about how much better she's gotten. So for those of you who are interested, this is a great podcast for you to hear what it sounds like for someone. Thanks, Lynn, for what it sounds like. So feel free to go and listen to this. But I also want to highlight another tool for you all, which is the movie Here Is Better. This is a movie that is now out on all major providers like Amazon, YouTube, Hulu, and some of them are like $3.99, $4.99. This is a documentary that was made highlighting the evidence-based treatments. So for those of you familiar with EMDR or prolonged exposure, this is a great movie because it highlights using the 3 evidence-based treatments. And while they're all veterans, they're not all combat. Some of them are sexual assault and other types of traumas. And it's not a heavy movie, so it's not like Saving Private Ryan heavy for 19 minutes. It does have a little bit of trauma stuff in it, but it's never the exact trauma rehappening. And it is the client's talking about it very briefly, but it's also more of going through the therapy process and seeing how these 3 treatments work. But the producer really wanted to get away from the crazy combat vet who shoots his best friends in the head and really wanted to focus more on what does actual treatment look like. And so what I did is just to prepare you all for it is I brought the trailer so that you could see the trailer of the movie and what it looks like. So this is the movie site. It is Here Is Better. And it's won quite a number of awards, including the GI Film Festival, Real Abilities, and things like that. But what I thought I would do is just cue up real quick this so that you can see what it looks like in terms of the movie content.
When we try and talk to you, you flip out and start screaming.
He would get really upset. It was like a very confusing fight.
I have some guilt. I felt like a burden to the people around.
It's scary. I can't do it.
And your friends are like, no, you have to face this. You can get really creative explaining away everything, but there was like a much simpler explanation.
Catherine, I've muted you and I can't unmute you for a second. You had a
Okay.
thing going on.
So maybe that's the problem. I think I've got it tied. So maybe that's why it killed the sound. So I think muting me takes away the sound.
Yeah, it sounds like it, but you had like a double thing going on, so I was trying to get rid of that. So I apologize to everyone for that.
That's all right. So I'm going to go ahead and back it up just a little bit.
Yeah,
and
sorry, thank you.
That's all right. No worries. No worries. Hopefully that's about the right spot. And let me go ahead and play. Here we go.
Some of the myth.
Think of PTSD, think of a guy that snaps and shoots his wife in the face. And that is not how it presents most of the time. It looks like depression. It looks like isolation. It looks like anxiety. But really, it's all of those things wrapped up.
It was a Vietnamese ground attack. What I saw, what I did, it still plays on my head. The training that teaches you that you have no right to your fear. This is just something wrong with me. I just must be messed up.
What's the worst trauma that you've experienced? Seeing my husband get blown up in front of me.
When I first announced that I was stepping back from public life and get treatment, I realized how many.
Now it looks like the video share had got killed. So boy, forgive me. We're just having a devil of a time. All right, hang on. I'm sharing this screen again. I'm going to get you to be able to see this no matter what I do. I'm not leaving without you being able to see this. How's that? Sorry, everyone. Okay, the sound is shared. All right, everything should be good. All right, tell me if you can't hear this.
Think of PTSD,
Thanks, Ray.
think of a guy that snaps and shoots his wife in the face. And that is not how it presents most of the time. It looks like depression. It looks like isolation. It looks like anxiety. But really, it's all of those things wrapped up.
It was a Vietnamese ground attack. What I saw, what I did, it still plays on my head. The training teaches you that you have no right to your fears. This is just something wrong with me. I just must be messed up.
What's the worst trauma that you've experienced? Seeing my husband get blown up in front of me.
When I first announced that I was stepping back from public life and get treatment, I realized how many people really wanted to talk about this.
This is the thing that happened. This is where your brain broke. And this is where we have to go back to fix it.
I don't want to take away your memory. I want to take away the control the memory has had over your life.
Trauma is trauma is trauma. It does not make a difference in what shape or form that it takes on, childhood, adult, whatever it is, it's trauma.
I can't drive my car. I'm paranoid that somebody is following me. You get that sick feeling in your stomach, you start sweating.
There is no magic pill for PTSD. If we can get that right fit of therapy to individual, we can actually make dramatic improvements.
We're going to fall. Question is, are you going to fall down? Or are you going to fall up?
If we work for it, we can be in total remission from our PTSD.
You know, make 2 steps forward, 1 step back.
I don't think it's ever too late to get your life back. It's giving me hope.
You didn't give up on me.
Here is better. Here is better.
Yay, it worked. So again, that is a movie that I think can be just helpful for you to be able to watch and decide if that's something that looks good to you. The one thing I love about showing that movie is you can see that's the most trauma I ever went into with her. I literally said, what's the worst thing that ever happened? She said, seeing my husband blown up in front of me. And then we never, ever had to talk about it in great detail because you could see how distressing that would be for her to talk about the day that happened. And so a lot of people think, but until she can handle that distress, she can't get better. But let's talk about how the brain works. We all have this amazing ability to compartmentalize, right? We have that ability to go from one horrible patient to the next and refocus our entire brain on helping the next person. And guess what? Do 3 more in a row. And we have the ability to have our kid be completely forgetting about their science experiment at 7 a.m. and say, guess what, Mom, Dad, I don't have what I need. And you now know you've got to get everything done as soon as you get off work to help them get this entire project ready. But you cannot think about it for the next 7 hours while you do therapy. We use this prefrontal cortex, this amazing part of our brain, to make that work. And so some people refer to PTSD as an amygdala hijacking because that whole flight, fight, freeze network is literally hyperactive and is overreacting to things. But the part that I think that leaves out is the fact that we have an underactive prefrontal cortex. So old therapies worked heavily on the amygdala. You know, we're going to do all this great exposure work. We're going to think about it. We're going to really activate it. But is there another option? Can we also focus instead on the prefrontal cortex to give them that ability to downregulate, to put things into boxes, to think about things when they're ready, and to guess what? Control the water faucet on their emotions, just like we do. We downregulate ourselves all the time. We feel like we're getting heated in an argument with our mate. And we say, you know what? I'm going to step back from this. This is not effective for you and I. I'm going to choose not to have this conversation right now with you. Maybe we come back when we're both a little bit of cooler heads, right? That's a prefrontal cortex. And that ability allows people to approach feeling their feelings about these things in a way that's much safer and controlled instead of just, you know, feeling completely dysregulated. So what a lot of clients find when using CPT and therapists is that it's not as distressing because there's not as much of that retelling and re-experiencing that you see in a lot of other therapies. So therapists often find that they are not dealing with as much secondary trauma because you're not going through as much of this traumatic material over and over again. But like I said, some clients do want to talk about it. We've got the written format of CPT, and we still have all the other therapies out there as well. You know, so if you look at the evidence, you've got CPT and prolonged exposure and EMDR kind of leading the way across the board as the leading evidence-based treatments, right? And this really gives us some options here in terms of what our clients want, right? So just to kind of bring that home, and then I'm going to answer some of the questions that you all have had. If you are interested in learning more, I do a monthly training for a training company. I have folks on there from all over Europe. I had a gentleman from Singapore on there last week. I couldn't believe it. He literally, what is that, 13 hours difference, maybe 11, depending on the time change. And so I do trainings, but if you are interested in getting together and talking about obviously, email Penny that you're interested in having me do either in person or Zoom training. I'll get up early for you all. And we can talk about how to do that. But if you're interested in just coming on your own, all of our trainings are listed on our website. And there is as well my private email. If you're interested in talking to me about something. In terms of trainings though, you know, come to one of our bigger ones, or hopefully you guys can arrange one just for you all over there. But what I would like to do is highlight a couple of the questions that people have been messaging to me. So I'm going to go ahead and stop the share just so that we can all have a nice talk about this. and make this bigger. So one of the things that a lot of folks have been asking about, and the first thing I do is I want to start with this idea of psilocybin and ecstasy, because I think it's a really important one. And like I said, several folks are in this area, amazing work that they're doing. But when we think about how memory is encoded, I think it's really important to think about how if we encode things in a more neutral way or positive way, it can really change the weight that that particular memory will have on our shoulders. And so one of the things that I know happens for many clients with the psilocybin or with the ecstasy is you don't feel as much pain. You feel and think about things in a much more neutral valence. And so when clients are asking, should I go and try one of those studies? Why would that work? I always highlight the idea that memories, once processed, lose their power. They lose their power. They lose that ka-ching. And so just even thinking about really wonderful things in your past, maybe a day you got married, the day you passed your boards, the day you had your child, the day you got a puppy, right? These can be wonderful days. And I know my kids have been known to call out, this was the best day of my life. And sure enough, 6 months go by, this was the best day of my life. And now, as years have gone by, I'll say, do you remember that day? And they'll go, oh yeah, that was pretty cool. And I'm like, it was the best day of your life, right? Because what happens as time goes by, the valence comes down from being the best day of your life to just being a day. But also things will do that from the worst day of your life, right? Can you remember things, in the middle of the night that you were agonizing about? You spent 2 hours laying awake about, when you got up in the morning, you went, why did I think about that all night? The answer is actually pretty straightforward. I just need to do X, Y, and Z. You're like 3 hours of sleep lost over something that by the light of day was pretty straightforward, right? Or things that you think about that you agonized about in your 20s. And once you hit your 30s, 40s, or 50s, you're like, I cannot believe I gave that much time, right? Or I can't believe I gave him, her, they, them that much time, right? Really thinking about what have I wasted my time on? Well, the beauty is we know that if we allow things to naturally process in us, they do tend to lose that balance, good or bad, they come to more neutrality. But when you feed things with negativity, right, then it continues to be the worst day of your life, this most horrific, horrible thing that has ever happened. Well, the beauty of the psilocybins and the MDMAs is that they allow you to re-experience those memories or just do the cognitive work without the heaviness, and so for a lot of clients who feel like it's just too hard, it's too hard to even approach the trauma in any way, this will give them a gentler way to get there. So I truly am excited about where those types of things can go. Another one that's also very exciting for a lot of folks is stellate ganglion block, where they're putting the nerve block here. The sad thing so far is that we're finding that for a lot of our patients over here, there's a study going right up the street for me, is that the data is falling off after about 9 months to a year. They're needing it again. And there is somewhat of a risk ratio, like they can hit one of the facial nerves. So that hasn't been effective, but that is also typically combined with like CPT or prolonged exposure, just like psilocybin or ecstasy. So someone said, it sounds like home practice is an important part. Would it be a barrier for someone benefiting? And can I give any examples of how they manage difficulties? Yeah, so yes. So motivation is important. And I do tend to try to find a lot of motivation. And like I said, Hannah, it can be anything. And I am malicious about this, right? I will literally use anything I can to motivate them. I will talk about after anyone goes in for rotator cuff surgery, goes in for heart surgery, goes in for hip replacement, what do they make them do? They're up and moving by the end of the day, right? And they will tell them literally, if you don't move, you will die. You cannot lay in bed after hip surgery. You cannot lay in bed after heart surgery. We have to get you up and moving. And then they'll tell you the following: after a knee replacement, if you don't do your exercises, this knee will not work. It will freeze up, right? And, patients will be like, okay, I want my knee to work. I'll do it. And like I said, I'll joke about Taylor Swift. I'll joke about video games. I'll joke about learning. I'll be honest. I've taken on sourdough bread making. Y'all, I'm a little bit crazy here because There is way too much science in sourdough bread making. I mean, the humidity level of your house, the temperature of your bread, and the temperature of your stove. There's a lot of science here going on. I'm like, okay, this is a lot. But how am I going to get good at sourdough making? Practice. I'm doing a lot of practice. And so use metaphors that'll fit that individual client, because what we're finding is that people are motivated to things that will give them change. The beauty of CPT is they often notice change quickly. So we see reductions in suicidal thinking, right? Most clients begin to show significant improvements within 3 to 4 sessions. That, not all, but most. And that's the kind of thing that motivates people when they start to feel that kind of, this is actually making me feel better. Then clients are more motivated to stick with it. It's just like workout programs. You know, when you find that it's helping you build muscle for your sport, or heaven forbid, you know, you're trying to lose weight or change a different healthy lifestyle, when you find that you have more energy because you're eating more protein, you know, you tend to stick with things. And so it's the same thing. CPT has to grab you. And so what we find is that by using the protocol, that people are getting more motivation, they're more focused, and it allows them to deal with stuff outside. And Hannah, right here, you know, that busy person, I'm like, do you ever sit in the child carpool lane? Do you ever sit in the pharmacy lane? How much waiting do you do for anything? I only need 15 minutes a day for you to do homework. 15 minutes a day. And you can either have it on worksheets, yes, which you can have on your iPad, you can have in a paper in a packet, but you can also have it right here on your app. So I'm like, why don't you open up your phone and let's look at your screen time and how much time you actually have spent on screen on your average day, right? So a little bit of screen shaming. Is that what that is? You know, and then they're like, oh, wow. Okay. Yeah, I spent an hour on social media. Can I borrow 15 minutes of that for a worksheet? Right. So I'll use a lot of tips like that and tricks like that to really help them realize I'm only asking for 15 minutes. And that really does seem to help a lot. Further, if people don't have English as a first language and use the app to dictate their first language, is there a way to translate those? That's a great point. I have seen someone, it's not built into the app, but I have seen someone who did that, and then they could export it and then use a translation device like Google Translate to bring it back over. I do know someone who's told me they did that. I think it was Hindi, maybe, that the person had dictated in Hindi using that, and then they translated it back with Google Translate. But you don't need to be able to read it. As long as they can read it back to you, then you don't need to be able to see it. But that's a great clarification. Great clarification. So what I want to open it up to is, this was just meant to get, you know, kind of a taste in your mouth about the therapy, that it is cognitive, that it's not forcing the client to talk about what happened. That becomes an option, a client option, that it's, you know, not something that you have to be trained with 3 PhDs in order to do this cognitive therapy. It's meant to be something very simple and very easy for you to use as another tool to help your clients get better. So what did I not answer for you that would help you decide if this was something you wanted to look into more, or if it was something you just wanted more clarification of, if you were going to be talking to your patients who might be getting it, or you might be referring them? So anything I didn't answer yet?
So I'm just going to allow mics and cameras if anybody wants to put their hands up and actually speak.
Thank you so much. So mics and cameras, so you can come off mute, and you can also come on screen if you choose, or you can continue to type. Thank you so much.
It'd be nice if we could put the hands up, though, to have some order.
There, hey, Amy, go ahead. Oh, Amy disappeared. Where'd you go? Thanks so much, Rachel. Oh, great. A couple folks. Okay, so I'll just pick as they came in. So Nicola, go ahead. Yep, just need you to unmute. Oh, can't unmute. Okay, she can't unmute.
Okay, give me a second.
Oh, there it went. Nicola.
Oh, I don't have a question. I just thought I'd show my face.
Oh, thank you for doing that. You know, it always does make things better. I so appreciate that. All right, well, I'm going to call on you. If you don't have a question, just wave me off. All right. So, I absolutely love that. Andrea, I saw you next.
I might have a silly question. CBT and CPT, the different? There's a lot of similarities. So what are the specific differences there? So that I do basic CBT in my therapy. So what would encourage me to use a CPT?
So the big thing is that if you look back at the history of, say, Beck, and even to some extent Clark, you know, there was no trauma manual written specifically for SD in the States. And so Patty Rezick was the one who went over, studied with Beck, and then went over and studied with Clark, and then came back and adapted CBT for PTSD. So if you look at, Beck put out his manual on depression, and then he put out his manual on anxiety and on personality and on schizophrenia. But where was the manual on PTSD? Well, that was Patty. They never went into that space on purpose, right? And so I know you've got Ehlers and Clark, right? You've got that work over there. This is a little bit different. And we've just put a lot of more focus on doing a lot of research on this with a lot of different populations, but you would find a lot of similarities between all of these different groups, because ours is just taking all of those fantastic CBT principles, but applying them specifically for trauma. Because we know CBT works for a lot, right? That's the joy of CBT. It actually does work for a lot of things. But that means for all of our PTSD patients, who, by the way, carry 3 comorbidities on average, it means that using something that works for all of those, if we actually tailor it also for the PTSD, right, then we're going to have a bigger improvement, right? And that's one of the beauties. That's one of the beauties.
Okay,
Yeah.
thank you. Thanks.
You're welcome. You're welcome. Emmy? Let's just unmute you.
Oh, yeah, I am unmuted now. How do you feel whether NETS would link to CPT?
You broke up just a bit. Can you say it again? Go ahead.
How do you feel NET therapy links to CPT? Because I think there's quite a few elements there that's
absolutely.
Yeah.
So narrative exposure therapy, we also have another version called written exposure therapy, that are very similar to one another. And those are more in the exposure world. Those are more in the write about it or talk about it over and over again, focusing back on that amygdala activity and going through it. This is the other side of the coin. This is where you never, ever, ever have to tell me the story. Ever, ever. I mean, I literally, that first sentence you saw in the movie where she said, "I saw my husband blown up in front of me," I never found out more than that.
Well,
never.
There's also a school of, as you, if I can say it like that, or an approach of that, which talks more about the feeling side and basically the flipping the narrative side of things rather than doing all this. Yeah.
Yeah, you're right. You're right. And so
of CPT
and the
basically.
flipping the narrative will focus more on the meaning. You're exactly right. And so, but again, a lot of the feeling ones will make them hold on to the feeling that they felt at the time as well. So they are putting them back in that, whereas we don't do that, right? They don't do that. And so for those clients that say this is overwhelming to me, or I can't do this, it's too much. Again, this is an option that doesn't feel like too much.
Thank you.
Right? Yeah, just another option. I always say it's good to have a lot of options so that my clients can come in and say, "I have to talk to you." Or my client who says, "I don't ever want to talk to you." I can meet them and I can go, "I have something for you," because clients will come in and say, "I don't think you can treat me because I heard you do this therapy." And I'll say, "Well, I do this therapy, but I also do that therapy." And it really helps to, because avoidance is part of the disorder, and avoiding people, places, and things that make them think of the trauma is part of the problem. So I feel like, forgive me, but I'm outflanking PTSD. It's always, but I can do this, or I can do that, or I can, dealing with their own avoidance that they've made up for why they can't come see me, right? Great question. Inez, go ahead.
Hi, I really didn't have a question. It was again like the other lady, just putting it on to sort of
totally appreciate it.
Say hello. But having listened to what you've explained today, it sounds very interesting because I come from the exposure side. So I'm prolonged exposure, Ehlers and Clark. So it works well for those people that want to go through that process. And often I've come across people with resistance to wanting to do that. So this is an interesting option in terms of working with trauma and not actually doing the exposure work. So it would be interesting actually to learn the protocols to see how I might be able to accommodate clients that don't want that, and also, as you've sort of highlighted, is addressing the avoidance issue, because we know the avoidance actually maintains safety behaviours around the trauma. So it would be interesting to learn how to work with that and their stuckness, and in my terminology, the hotspots, that stuckness, without actually going through the processing of the trauma, whether it be, the verbal way or the written way. So I'm really curious about how it might work.
Good. Oh, I'm so glad.
For
I'm so
those
glad.
clients.
Like you, I'm trained by Edna Foa in exposure therapy. Dare I say it? Oh my goodness, 33 years ago, a long time. And like you said, exposure is great for those people that are just dying to tell you about it, or those people who are even subtly resistant about it. But for those people who literally will say, I'm dropping out of therapy if you make me do this, I can't handle that, then we start talking about words like readiness and fragility. And I would rather talk to them about another treatment instead of, all of this prep work. And it goes to a question, then I'll come right back to you in just a second. But this question that came in of, how about prep work? How does this fit into a phased model? Do we really need the stabilization phase? And I think you hit the nail on the head, right, Lucy? We don't really need stabilization as much. Now, don't get me wrong. There are clients that are just not ready. They're so high on dysregulation, so high on dissociation that I am a big fan of DBT work and using some distress tolerance or emotion regulation to stabilize. But if the issue is they're not ready to tell me about the trauma, guess what? I can take off all stabilization work and start them right away with the trauma therapy using CPT, right? Really great, really great. All right, Claire, go ahead.
Hi, it kind of feeds into those last 2 points, and you referred to using this in people who were having ongoing trauma in terms of occupational issues. I wondered if you had experience with people who had trauma from medical or surgical intervention who still need medical, surgical intervention and treatment. So you need to deal with it fairly quickly so that they don't miss out on whatever treatment it is that they need.
Can I tell you one of my fun stories that happened in my life? I have a wonderful cardiologist who does research in my hospital, and she dropped by my office and she said, hi, Kate, great to see you, but I got a problem. And I said, well, what's going on? How can I help? And she's like, I was hoping you'd say that. And I'm thinking, what does a cardiologist need from me? And she says, I have a guy who needs a new heart. And I looked at her, I said, that sounds like a you problem, not a me problem. And she says, he's going to die without one, and he has PTSD. And I said, still not getting it. It's a you problem, not me problem. You need to get that guy a heart. She says, Kate, he's smoking pot every day. And I went, oh no. And she says, why is he smoking pot, Kate? And I said, because of the PTSD. She goes, yep, he is so angry and he is so frustrated with his emotions. He is smoking pot every day. And that's a no-go for a heart. I need him better. And I said, how soon? She goes, he'll die in 3 months. Make him better now. And I went, got it. And she said the bottom line wasn't just have him not smoke pot. It wouldn't work. He would become so dysregulated. His heart rate would go up and he was a train wreck. And so what we did is we immediately started CPT. He started reducing his pot almost immediately, so that by the time we were done, he was better. And then, so that's one crazy situation I had that was a beautiful success story. But I've had other ones where like they had a surgery that went wrong and they actually have PTSD from the original surgery. And now they have to go back in for the correction surgery, right? And so I've had botched plastic surgery. I've had, a person who went in for a diabetes sore and they castrated him, right? And now they need to go back and do the correction surgery for this accidental castration. And he's scared to death to go in and think they're going to kill him, right? He woke up no longer a man, his words, and now he's going to wake up no longer not waking up, right? And so again, but he needs this surgery now because the skin is needing to be addressed in terms of this castration. So again, yes, and yes. And that's the beauty of being able also to deliver it intensively is if I'm on a time frame, I can get the help that they need quickly to allow them. And sometimes I find that if patients opt for more of an exposure-based treatment or even EMDR with me, they don't want to come in daily as often. Sometimes they do, but sometimes they don't. But with CPT, I see them more willing to come in and do fast-paced therapy, especially when I'm on a timeline and I need to, get them to a new job or get them ready to go to court. I do a lot of people are testifying. And lawyers say to me, I don't want them so dysregulated that they look bad on the stand that no one believes them. I want them emotional, normal, as a lawyer said to me. I want them emotional, normal, not so dysregulated you can't even hear them testify, right? So I've done fast CPT to even allow people to testify. Yeah, great question, Claire. Thanks. Karen, did you have one as well? Sure.
Yeah, thanks. It's absolutely fascinating, and it follows on from Claire a little bit in that we're running a long COVID service, and we've had the absolute joy of having a psychologist in that MDT, in that multidisciplinary team. So we've seen people who've been traumatized by their COVID experience, both treatment and loss of others. But also, interestingly, we're seeing more and more people who are quite happy to acknowledge their trauma. So we've got a group of people who are very medicalized, but we've also got this kind of emerging sense of people recognizing actually that's all these labels they've been given around fibromyalgia, chronic fatigue, chronic pain. Actually, their childhood trauma is actually the thing, and they're actually ready to talk about it. And I just wondered if you're seeing more of that move away from the medical model and interest in actually other routes and more openness to that.
It's funny you say it that way because I never thought about it that way because I still think of CPT as being medical model, right? It's just a different lens. So it's funny you say because I'm like, but we are, and I was going to actually, before you finished your question, I was going to say, so I would go medical model. So I'll have to think about recalibrating my answer because I just think so much about patient choice that, like you said, so often they get into this framework. When I work with a lot of first responders, they know so much language about first response and stress and all of this, but I'm like, but that's you. And we need to talk about your PTSD. And they'll say, well, I understand all the situational variables with my job and rescuing, blah, blah, blah. And I'm like, can we talk about the day your dad broke your arm when you were 7, right? And so the nice thing about CPT is it allows you to work on more than one thing at once. And so I have it kind of in my back pocket to always go, but on the intake, I noticed you have this, but I also know, could you just do one sheet on this? And so it allows me, once they've learned the skills, to say, let's try this, let's go ahead and not forget this, because sometimes these other things are important. And even if they say, I don't have trauma from it, which I believe, because I know people are very resilient, and, we could have another wonderful lecture where I'll come and join you all on who gets PTSD and who doesn't, and what some of the research says. But I always think about the idea of, you don't have to have PTSD from it to still have it be stressful for you. There's a difference between traumatic and stressful. And just because something isn't traumatic doesn't mean it's not stressful. So let's talk about that. Is this stressful, and can we add that into the therapy? Or so many of you working in medical scenarios, you know, just because you don't have PTSD from something doesn't mean your husband leaving you because you're dealing with something, or your wife cheating on you with your 2 best friends isn't stressful. We can add that into CPT. And I like that about it versus, you know, I felt sometimes with my exposure-based therapies, I couldn't add in these present tense things. Whereas with CPT, I can do this and this all at the same time, right? Which really does help.
Right.
Someone asked, when would I choose EMDR over CPT other than patient choice? So thank you for answering the first part, because it's always patient choice for me. I'm glad I was heard. It's always patient choice. And I'll use the shared decision-making tools from the National Center. I'll use whatever I can to try to really get across that idea of, I can educate you on all of these, but these are the ones that are most effective. I try desperately to never tell them which one to do, because I don't ever want that accidental blaming of me for telling them the wrong choice. And I do a lot of personality disorder patients, and I never want to set us off for a bad foot with me saying, well, I think you might like PE better. What I do more of is just, these are the main ones. CPT and PE have the most evidence. EMDR is right behind. It's never been tested in combat troops or first responders, but I've been funded to do that study, and it's never been compared to CPT or PE. I've been funded for that study too. So I'm comparing CPT to EMDR in veterans and in first responders, so we can get that answered for us. And so I talk about that. You got the 2 lead, then you've got EMDR next, and then you've got the other up-and-comers that are all looking good, but these are the evidence. And so we talk about couples based with Candace Munson, you know, we talk about all of those. And then I help them just kind of say, based on what you think you want to do and how you want to process, which of these would you like to do? And I try to make sure I surround myself with colleagues that I could send them off to, right? So that even if it wasn't me, that I could at least send them off to. And if it was just you and you were the only one, then I would just, you know, make sure you're trained in more than one so that you can give them that option of talk about it, don't talk about it. I think that's a really reasonable thing, right? So did I get to all the questions? I think I did. So let me end this by saying, you know, thank you so much for giving me your afternoon and for willing to talk about something that's obviously near and dear to my heart. Truthfully, I never wanted to be a researcher. I never thought I was going to develop a therapy. I just wanted to work with kids, and I wanted to help people who'd been traumatized. And I think was just so startled by the fact that there wasn't an answer when I came a calling and said, what do I do? What do I do? I don't want to just say, hi, how are you? And ask them about their feelings. What do I do with people who've been traumatized in childhood and severely traumatized? And how do I help make a difference? And I think my propensity for asking questions, as my parents would say, led me to a wonderful path of becoming a researcher and just willing to ask a lot of questions about how can we help people get better in other ways. And now here we are today. So thank you so much. And so I'm going to turn it back over to Penny and just say, I appreciate her. I appreciate Darren for connecting me to you and giving us this time. But hopefully people can give some feedback to Penny and let Penny know. I know they're thinking about trainings they'll do in the future. And I'd be more than happy and interested in coming back and chatting with you all again in the future. All right. So thank you, Penny.
Much, Kathleen. Thank you. Thank you very much. And I was also going to thank Darren and so Darren Bambridge and Emma Aguala for all the work they've put in to make this happen and to link us in with you. So there's our Emma. Thank you very much, Emma, for everything you've done, and to Darren as well. I know it's been quite an early start for yourself as well. So thank you very much. And I think everybody's very pleased what we've done and what you've been able to deliver today. So thank you.
You're very welcome. And the slides will be shared. I did make them available. So there you go.
Lovely. If you can get this over to me and I'll get them uploaded. And if anybody does have any questions or would like me to get you in contact with Kathleen, I'll put my email address in. Well, I'll put the CTM email address in here for our general communications so that you can contact them.
Wonderful. Everyone have a wonderful day. It was a pleasure seeing you all. All
And
right.
you. Thank you all.
Thank you.
Bye.
Thank you. Bye now.
Thank you very much. Thank you.